Hello and welcome to our second live event tonight. We are back with one more online patient meeting tonight. And as always, I am your host, Caroline. And please just let me know if you can hear me. And Dr. Valentina, can you hear me?
Yeah, I can hear you.
Perfect. Thank you for confirming that. Hello to St. Petersburg. How are you feeling?
I'm fine and I'm ready for our conversation. So
perfect. Happy to have you here. First, let me just remind everyone how it all works. And of course, we are here simply because we want to make sure, and also we want to give you an opportunity to find out and ask your questions to the top fertility experts so that you can get prepared for your treatments. As of now, all of the clinics are shut down simply because of COVID-19, and because of that, the Stronger Together initiative has been simply put in place so that you can use that time to find out and to ask and to learn as well as to know to meet lots of experts in that field, and some of them are right here, and those are our ambassadors or partners. You can see all of them here, and thanks to them it is actually possible. The whole Stronger Together initiative has been created with the great help with those experts as well. So huge thank you to them, of course. And I already have mentioned that today we are having another topic to handle, and with us Dr. Valentina Denisova. She is obstetrician gynecologist at International Center for Reproductive Medicine, located in St. Petersburg in Russia as well. And today she will start with her introduction on why IVF with donor eggs may fail, and reasons and prospects for the patients. And after that, we will go with the most common questions we receive from the patients. And then it will be your time to ask your questions. So remember, you can type those questions in the chat section. And after that, we will take care of them for you. And Dr. Valentina will answer one by one. Again, let me remind you that this is being recorded, so you will definitely have a chance to watch it again. And the website where you can find such videos, this video particular one, is in the chat section as well. Well, that will be it from me at this point. And well, Dr. Valentina, are you ready to start?
Yeah, I'm ready. Thank you, Caroline, for the introduction, and good evening, everybody. It's nice to say hello from the city of the White Knights, from St. Petersburg. And as Caroline has already told, my name is Valentina Denisova, and I'm from International Center for Reproductive Medicine, and it is one of the oldest IVF centers in Russia. And it was founded more than 25 years ago by Dr. Yuri Verlinsky. He was a pioneer of pre-implantation genetic diagnostics, and he founded our center as a branch of Chicago Genetic Innovations. So that is the reason for the name of our center, International Center for Reproductive Medicine. And during these more than 25 years of experience, our center was the first in several achievements, like first pregnancy after ICSI, and we created the first egg donor bank in Russia. I mean, first egg donor bank, and the first pregnancy and childbirth in surrogacy program. After that, we created the first cryobank with vitrified oocytes and some other achievements. So that was the few words about our center, and now I shall talk about our topic. Why should we talk about this? Why should we talk about IVF failures with donor eggs? When the patient decides to use the donor eggs, it's always a very hard decision for the patients, and patient will be particularly disappointed if this attempt will fail. The psychological and financial matters are very important. First, it's important because IVF failure is always like a shock for the patient, and despite of the notice about their real chances and absence of guarantees before the starting program. And the second, financial, is very important because the price is really high, and insurance in most countries doesn't cover such type of program. Money is matter. Talking about the price and the cost, I have to say that costs for egg donation program in our center are looking more attractive than in another countries. On the average, it is about $4,000 US. But meanwhile, like in all other centers in all other the world, unfortunately, we cannot achieve this 100% pregnancy rate. So the problem is still matter. And what is the most common reason for usage of donor eggs? I think it's advanced maternal age. And the basis of this reason is the male reproductive system physiology. One of the main features of female reproductive system is that all the oocytes have already been founded during the fetal development, and the number of oocytes and the quality are decreasing during the following life. And unfortunately, we cannot find a way to stop this process. And also there can be some another indications for donor eggs, like absence of oocytes due to different reasons, like premature ovarian failure or poor ovarian reserve after operations, chemotherapy, genetical diseases, and so on. And also a very wide group of patients with low or poor response also can be a candidate for egg donation. Who can be an egg donor? Since I'm working in Russia, and I have to follow Russian guidelines, and considering our guidelines, person who wish to be an egg donor have to be younger one, 35 years. She should be with good somatic and gynecological health. Also, she cannot have children with congenital diseases or history of recurrent pregnancy loss, some kind of diseases which could be transmitted to the patient, like HIV, for example, or some kind of chromosomal disorders. In our center, egg donors pass some additional genetic tests, except karyotype. We also are examined for genetic disorders which are most common for European population. But in spite of such wide examination and young age of egg donors, sometimes these programs can fail. And tonight we will discuss possible reasons of failures and what we can do to avoid these failures, what we both, I mean doctor and patient, can do to improve chances for success and to short the time to your dream become true. And as Karen has already told, in first part, I shall try to shed the light into the most frequently asked questions and when you can ask your own questions. I'm ready for the most frequently questions.
Perfect. Thank you so much for a lovely introduction and explaining some of the details already. And yes, it is time for our common questions. So let's get to it right now. Here's the very first question. So what can I do to change the result of an IVF with donor egg?
Yes, this is one of the most commonly questions because always when patient come to the office and we are discussing the following program, we are interested, what can I do? First of all, I need to say a few words about an embryo because the preliminary step of ART, assisted reproductive technology, is the fertilization of the oocytes by the sperm, and then transformations which occur in the zygote. They are monitored by clinic, and we try to determine the embryo quality. And the embryo quality is assessed on the basis of several parameters like morphological, developmental, genetic, and metabolic. And the quality of embryo is dependent on the quality of oocyte, what created it, but some of parameters can also be influenced by paternal factors. We are observing that the transfer of even euploid embryo results in implantation rate at approximately 60%, while almost 40% of embryos remain unaccounted for. Some losses can be accounted for by endometrial factors, but the residual lost embryos could be partly accounted by paternal factors. And what factors can be changed by patient to improve the chances? I think the first factor is overweight and obesity. We know that pregravid overweight and obesity are associated with increased risks of some kind of complications like gestational diabetes, hypertensive disorders, preeclampsia, preterm birth. So we realize that for these women, it can be very hard to lose enough weight to normal BMI categories. And we suggest for these women to lose weight to 10 or 15% reduction in pregravid BMI. And that could be useful to reduce these risks. But for overweight patient, even 5% of reduction of BMI can be helpful. That's surprisingly, but for male, obesity is also can influence on result. We know that obesity is associated with higher risk of infertility in male, and it is regulated on epigenetic level in sperms, and also it can influence on embryogenesis and even on health of offsprings. Animal studies have shown that male obesity can lead to the risk of metabolic and reproductive disorders in offsprings. So both patient, male and female, can lose weight before they plan program. What else? For male, cigarette smoking can be a potential risk factor for decreasing fertility. We know that sperm concentration can be lower, and cigarette smoking can be negatively associated with sperm count, motility, and morphology of the sperms. And the same for alcohol intake in males, and it can has detrimental effect on semen volume and sperm morphology. And this is especially for chronic alcohol intake. What can we change in the lifestyle for female? Of course, we can change smoking. Of course, we can change alcohol intake, because both these factors are associated with miscarriage during early stage of fetal development. And where is no safe dose of alcohol during pregnancy, it can lead to some kind of pathologies on the child. For female, also stress factors may also impact the result. We know that elevated cortisol levels lead to almost 3 times greater chance of miscarriage within the first 3 weeks after conception. in comparison with patients with normal cortisol levels. So we suggest to exclude some stressor factors before planning pregnancy, before planning IVF. So, was it the answer?
Perfect. Yes, definitely. Thank you so much for the details. Very, very useful indeed. And now let's go to the next question here. What gynecological condition can lead?
Gynecological conditions. Yes, talking about gynecological condition, I suppose first of all we have to talk about fibroids, as this is the most common benign uterine tumor, and evaluation by ultrasound reveals the incidence of fibroids about 40% at the age of 35 years, and the incidence rise up to almost 80% at the age of 50. And these myomas or fibroids can influence fertility by different mechanisms, like distortion of the uterine cavity and altering myometrial contractility, and they can lead to chronic inflammatory reaction, which can influence on implantation. What can be our suggestions or treatment options when we see patients with fibroid? First of all, I'd like to say that operation is not always needed, but it is necessary in case of submucosal fibroid, and in all these cases, then fibroid can influence on the womb. But in some other cases, we can use therapeutic options like GnRH analogs, selective modulators of progesterone receptors, and some other options. And we have another gynecological disorder which can also influence on result, and this disease is called adenomyosis. It is also benign uterine disorder, and it is characterized by invasion of endometrium into the myometrium. And adenomyosis may impact fertility by increased uterine contractility, impaired endometrium receptivity, some alterations in the expression of cytokines and growth factors within the endometrium. And also there are several other conditions which can also lead to implantation failures, and they are like autoimmune antibodies, antiphospholipid syndrome, hereditary thrombophilia, some kind of infection. So there are a lot of disorders which can lead to failures. And I suppose that before planning IVF, patient need to try to find out this possible reason and to correct it. We need to correct intrauterine pathology like polyps, adhesions, fibroids, endometrial hyperplasia. In some cases, we suggest our patients to perform laparoscopy and to do salpinectomy, especially then we can find hydrosalpinx or some other pathologies in the tubes. And of course, correction of concomitant diseases. That all can be very important before planning pregnancy, before planning IVF.
All right, perfect.
Yep.
Thank you so much again for detailed answer. Thank you so much.
Yeah.
Okay, now let's go to the next question. So what about MACE factor?
Male
What abilities do we have today?
Oh yeah. This is a very important question, because for many years we used to think that only oocyte quality can influence on success rate, and our attention was paid to females' health. But right now we realize that male factor matters. We know that sperm aneuploidy or abnormalities in sperm chromatin have to be reported to correlate with chromosomal abnormalities within the embryos. And also sperm chromatin may also impact result of our programs. We know that increased percentage of immature chromatin in the sperms is associated with a lower fertilization rate and slower embryo development, so it can influence on result. Right now is very popular topic is DNA fragmentation of the sperms. It can be caused by environment, radiotherapy, chemotherapy, reactive oxygen species, and so on. And talking about this point, we know that current methods of detection and correction of DNA fragmentation, attempts to find the best sperm, they are very different, and the results are controversial. So we need to following studies in this topic. Definitely, another important point is Y chromosome microdeletions. They of course affect spermatogenesis and they affect IVF results. And I think I have to say a few words about paternal age, because we used to think that father's age doesn't matter. But last years we realized the importance of paternal age, and most commonly studies revealed that paternal age over 50 years old is associated with high percentage of epigenetic changes, higher frequency of DNA mutations within the sperms, and impaired spermatogenesis, and thus this decrease the success rate of our program. And also we can find the risk of some kind of diseases in offsprings, like autism, like psychiatric disorders, like bipolar disorders. So the advanced age is matter.
And perfect. Thank you so much again for explaining the details for this particular question. This is definitely an important factor, and we will definitely have more questions on that.
Yeah.
So thank you so much. And why do not all embryos implant? Is PGT, PGS the solution?
Oh, that's very important, and that's a very popular question. We know that not all the embryos are euploid, and aneuploidy is the most common reason of failures. This is the fact, and we are sure in this fact. Actually, to receive one euploid embryo, we need at least 6 oocytes at the age of 35 years. 35. So one of the questions is how many donor eggs should I choose? Patients always interested in it, and this can be very important when we are talking about frozen eggs. Several studies revealed that pregnancy rate using fresh and frozen eggs is similar. Then we fertilize the same number of eggs. So if in fresh donor cycle, usually we retrieve about 15 and probably up to 20 eggs, clinical pregnancy rate is more than 50%. I think it's about 52%, something like that. So to achieve such a good clinical pregnancy rate around 50% while using frozen eggs, we need about 15 eggs. And our suggestion for patients to use at least 12 eggs. And so when we choose more eggs, it is much more easier to find a healthy embryo. and the chances will be higher. And another possible option is PGT, pre-implantational genetic testing, and especially pre-implantational genetic testing for aneuploidy, because PGTM is for patients with chromosomal disorders, but here we are talking about PGTA. In fact, when we use donor eggs, PGTA is not necessary. But in some cases, especially when a patient has already had few unsuccessful IVF attempts, PGTA can be a solution and they can choose this option. In our clinic, we perform PGTA by RSGH and by NGS, and in my opinion, the most common genetic testing is NGS. But what is important that to understand what no one of these methods cannot give a 100% guarantee to have a healthy child at the end. Because some mutations may happen de novo, I mean after we have tested the embryo and even after the transfer of the embryo into the uterine cavity. And also we cannot deny influence of pregnancy and its complications on the health of offspring. So in some cases PGT can be a solution, but in some cases patient can just choose more eggs. I think.
Okay. Thank you again so much for explaining all the details of this matter as well. And this will be our last question when it comes to those most common ones. So then we will go to your questions. So again, let me remind you that you can type it in the chat section, and Dr. Valentina will simply get back to you with some details and advice as well. And so the question is, what is the role of endometrium in implantation failures?
Yes, the implantation and the endometrium, they are very close because implantation relies on a crosstalk between the embryo and the endometrium. The facilitation of many different factors such as growth factors, cytokines, cell adhesion molecules, transcription factors, and so on. So this is a very complicated process. And the window of implantation, which exists then optimal environment of these factors are balanced, usually lasts only for a few days and begins around 6 days after the ovulation. And one of possible mechanisms which is involved in implantation failures and especially in recurrent implantation failures is the change of endometrial receptivity, of possibility of endometrium to attract the embryo. And one of changes of this receptivity might involve the shift of timing of the window of implantation, which previously was assumed to be the same among all women. And regulation and dysregulation of many different genes are implicated in these changes among the endometrium window of implantation. And one of options can be the endometrial receptivity array test or error test, which is used to identify the window of implantation changes on the basis of more than 200 genes among these patients. And the first studies in this field revealed that window of implantation is shifted and in almost 25% of patients with recurrent implantation failures, and after the personalized embryo transfer on the basis of error test, the rates of implantation climb to the rates of whose patients with receptive endometrium with normal window of implantation. But during last few years, the results of another new studies bring some controversy to these results. So I think we need further studies in larger samples to identify the effectivity of this test. But in some cases, of course, we can use this test. And another reason of implantation failures can be chronic inflammation within the endometrium, I mean chronic endometritis. And this is a pathology that traditionally is diagnosed by histological examination and by the visualization, the hysteroscopy, and bacterial culture. In some cases, we can add some additional tests like immunohistochemistry stay for diagnosis, and also we can reveal the bacteria which can lead to this process. And in these cases, of course, we can add antibiotics before the embryo transfer or cycle before the embryo transfer. It will depend on each clinical case.
And
So,
thank you so much
yeah.
for answering those questions in detail. Really appreciate it. Thank you a lot. And as I've mentioned, now it is time for your questions, our patient questions. So there are plenty of those already. So let's get to it. Dr. Valentina, are you ready?
Yeah, I'm ready.
Perfect. Okay, so let me go to the very first question here. Is there a better medication to use than the progesterone and estrogen for gestation?
Well, it's a very interesting question, and well, in fact, this is one of my field of interest about luteal phase support. If we are talking about different studies, and there are a lot of studies, there are a lot of meta-analysis and clinical trials, and in fact, we don't know which is the best form of progesterone and estrogen for gestation. And if you are interested in what is better to you, one progesterone and estrogen, we can use both these forms. Of course, we use progesterone in all cases, in all IVF cycles, because progesterone is needed because we have luteal phase defect in IVF cycles, but estrogens are not always needed. We can add estrogens in some cases, especially when we are talking about thin endometrium, or when we are talking about frozen embryo transfer cycles. We often use estrogens also.
Perfect. Thank you so much for your question as well as your answer and advice on that. And now we have another question. Do you recommend hysteroscopy for patients who has a history of few failed IVFs with Onyx before starting donor?
No, in most cases, I recommend hysteroscopy if patient has already have few failed IVF attempts. Because we can find some pathology like I've already told, for example, chronic endometritis. So we can improve chances, I think, in this case. Yes, in most cases recommend, but in some cases, especially if, for example, patient has tried at the age after 45 years, we realize that the reason, the most common reason it's such advanced age is quality of eggs. So if that was a few attempts at the age after 45 years old, it is not necessary for all patients, but for most of them it is needed. Yes.
And thank you again for that. And so, how important is the 3 minor line in a donor egg transfer? Is this one a determinant of being successful that leads to a positive outcome?
The trilaminar line can be important, but actually we evaluate the thickness of endometrium. This is not only one option to determine if they can do this if they can do transfer in this cycle, or we cannot do the transfer. I think endometrium thickness will be more helpful than trilaminar line. Yes.
And thank you so much again for your question and your answer to it. Okay, let's go to the next question. I heard many women advise to cut the amount of sugar to minimum before IVF, sugar detox. Does this method have any proof results?
About sugar consumption, you know that during the 20th century and 21st century, we consumed a lot of sugar, much more than we needed, really. And the problem is the high incidence of diabetes mellitus, and if a patient has some problems with the sugar level, of course, we need to exclude sugar. But if a patient has no problem in her endocrine system, I think she doesn't need to exclude sugar in her diet.
Okay, great.
Yeah.
Much again for providing that answer to us as well. And now let me go to the next question. If an embryo was created using a donor egg in early March, do you think the clinic should contact the donor to see if they have developed COVID-19?
Right now, we are worrying about the COVID-19, in fact, there is no data that COVID-19 can be transmitted through the eggs. There is no reason to find out COVID-19 in the donor but COVID-19 can influence on pregnancy, and it can influence on IVF results. So, as you know, right now, most of international societies they have made a suggestion to stop all the new cycles, and we are waiting for the finishing of this epidemic of COVID to continue our programs.
All right, perfect. Thank you so much for clarifying this this for us as well. Definitely interesting and so common right now as well, I would say.
Yeah, very common.
Exactly. Okay, there's another question here. So, are there differences between two samples of normospermic male patients with different age? For example, between a normospermic sample of 35-year-old and one sample of 50-year-old.
Yes. Well, I think this is mostly question for a urologist or maybe for embryologist, but I will try to answer. As I have already told that age can influence on sperm quality, so and it can influence on epigenetic changes on ploidy of sperms. I think if we will compare the prognosis while using the same normal sperm example of the younger male and the older male, the sperms from the younger male will be better, and the results will be better when we use sperm of the younger male.
Excellent. Again, thank you so much for that question and your
Yeah.
answer to this. And now we will go for a different one. How to choose an egg donor? Should I choose a woman who has a history of 50 eggs retrieved, or should I rather choose less extreme number like 20, 25 eggs, hoping for better quality than quantity?
Oh yeah. This is a really rare case when we retrieve 15 eggs, and as we can see from clinical practice, when we retrieve such a huge amount of eggs, not of them will be very good, and some of them will be can be immature. So I don't think you have to choose an egg donor with a history of 50 eggs. 20-25 eggs is a very good response, and that will be enough for with pregnancy rate about 50-52%. I will repeat that 20 eggs is usually is enough to have 1 or 2 embryos to day 5 for the transfer, and in these cases usually we can freeze down a few good embryos after the transfer, the best one.
All right, perfect. Thank
Yeah.
you so much. And now let me go to the next question. So my only tube is blocked. Will that be a problem for me towards IVF?
Well, only blocked tube is not the problem. The problem is then we can see the tubes like the bags, like we call this problem hydrosalpinx, and these hydrosalpinx can be a problem for IVF, and we suggest to remove such tubes because this is the source of infection and source of inflammation, and the implantation cannot occur when we have a lot of inflammatory environment. So in most cases we recommend to remove such tubes.
And again, thank you so much for answering this question. And let's go to the next one. So, do you recommend intravenous immunoglobulin for high NK cells? If not, what other alternatives are there? I am very confused about what my immunologist advises and what my doctor thinks about it.
Well, since I'm not the immunologist, I'm a gynecologist and a fertility specialist, so I cannot recommend and give any suggestions if the specialist in this field recommends this. But as I know, there are a lot of studies in this field, and some of them have shown good results with immunoglobulin. In some cases it works, it really works. uh, so if your immunologist recommend this, and if you really have problem with recurrent implantation failures, they can recommend this type of treatment in case of recurrent pregnancy loss. Yes, in some cases we can use this, but only with the recommendation of the specialist in this field.
Thanks so much again for your question. Very important one for sure. And also, I just wanted to remind you that if you would like to get in touch with the Dr. Valentina, and also her team, you can use the link right here. I'm sending this via chat right now, and you will be able to ask any questions you might have, of course, as well. And now let me go to the next question. So, do you have the photos of donors at your clinic, and in what age? Only when they are children?
Yeah, we have photos of donors, and we have photos of donors at the childhood age, and some photos at the adult age. So you can choose the best one.
Perfect. Again, thank you so much for answering this one. Quite common question for sure as well. And let's go to the next. So, can menopause change the uterine layer structure, making it difficult for implantation?
Menopause itself. It doesn't influence on possibility of implantation because in clinical practice we have an examples of pregnancies even after more than 10 years of menopause because in such cases we use hormonal replacement treatment to prepare the uterus for the implantation, and the endometrium thickness will rise up to the optimal. So this is not a problem. But if we are talking about the age, and especially advanced age, we need to remember about the pregnancy and possible complications during pregnancy. So they have to think about what will happen with this patient after pregnancy. And so if a patient of very advanced age will come to the clinic, we will discuss if we need to do this pregnancy, if she need to bear by herself.
Okay. Thank you so much again for that. And there's another question here. So, what form of progesterone do you recommend? Vaginal, pessaries, or subcutaneous injections or progesterone gel? What's the usual dose? Example, is it 600 milligrams pessaries, or do you prescribe more? What about estrogen for frozen embryo transfer? Do you recommend 6 milligrams taken orally, or is it better to insert sorry,
Yeah, I understand. For progesterone, because considering the meta-analysis, considering different studies, all these forms had the similar efficacy. But um, in different countries, we have different forms of progesterone, which we can use. For example, we don't have subcutaneous injections of progesterone in Russia. We have vaginal forms, both pessaries and gel. We have oral form of progesterone. We have intramuscular injections. So that's totally different, and that depends on the country. But each form works with similar efficacy. As for the usual dose, yes, 600 milligrams. It's usual dose, but sometimes we can prescribe more. And what about estrogens for frozen embryo transfer? I think oral form is more comfortable for patients. But in some cases, I prescribe transdermal form. We don't have vaginal form of estrogens in Russia, but we have transdermal forms in gel. So we use both of these forms. As for the daily dose, we can use up to 10 milligrams per day, so we can even combine these forms for the more comfortable use in different patients.
Okay, perfect.
Yeah.
Thank you again for that. So here's the next one. Second attempt with own eggs. None of the embryos reached the blastocyst stage. Also, the AMH level is 1.07. Do you recommend for the next attempt to proceed?
Well, if that was a second attempt, well, that depends on your age, because on your age, and also that depends on results of your partner's examination. So in at advanced age, I will recommend donor eggs. But if we are talking about young patient, probably we will try to find another reason and another option. Like we will try to examine male and trying to find out the reason there. And actually, after the third unsuccessful IVF attempt, probably I will recommend egg donation, no matter of the age of patient.
Okay, thank you so much again for that. And let's go to the next question. Why are they doing more cesarean than natural births? Which do you recommend if everything is basically normal?
Well, this is very important. I think the incidence of cesareans is rising because of psychological points of our patients, and especially when we are talking about patients who conceived through the IVF, and then this is not the first IVF attempt. Of course, patient is afraid of something will go wrong during the natural delivery. In such cases, probably doctors will prefer cesareans. But in fact, IVF itself is not an indication for cesarean section. So if there is no another problems, if there is no any problems with somatic health, with pregnancy managing your, after the IVF, if there is no any obstetrical complications, so why not natural delivery?
And again, thank you so much for clarifying that to us. Well, and now let me go to the question. So, how do you determine the time for embryo transfer if patient doesn't have a cycle as one, maybe in is premenopausal?
But, well, in patients who has irregular cycle, who has some problems with ovaries function. We before planning IVF, before we prepare to the embryo transfer, we will prescribe hormonal treatment to regulate the cycle, and that would be the cycle, not natural cycle, but cycle with hormonal replacement treatment. Um, so we will prescribe estrogens, and then the endometrium thickness will reach at least 8 millimeters. I think the optimal thickness is about 10 millimeters, and from 10 to 12 millimeters. And then we will prescribe progesterone, and the duration of progesterone intake will depend on stage of embryo freezing or stage of embryo development.
Okay, thank you so much once again for this one. And we have a different question here, actually. So, does religion it's a part of the background check of the donors?
The religion is not a part of the background which we check for donors. That's not necessary in Russia.
Okay, perfect. Thank you so much for answering this one as well. And we have like 3 questions left. So just let me remind you that
Yeah.
if you have any questions that you would like to ask, this is your time to do it. So go ahead and type it in the chat section. Dr. Valentina will definitely get back to you with some useful explanation and advice. Okay. This is a simple question. So, do you have online consultations in your clinic before coming?
Yes, we can provide online consultations in our clinic through different types of services. First of all, you can contact our doctors by emails, and you can contact our manager for international programs, and also you can contact us and get this consultation through online service on doc.
Perfect. Thank you so much for that as well. And just one more thing, just wanted to add, remember that you can use the link that I have sent you in the chat section, and you can actually you can just get in touch with the team and Dr. Valentina using this. You just need to ask your question there. All right, and now let's go to the next question. So, is there an advantage with fresh donor eggs comparing to frozen eggs?
Uh, well, um, if we are talking about the same number of eggs, there is no any advantages of fresh donor eggs. But when a patient chooses a small amount of frozen eggs, the pregnancy rate can be lower when we use fresh donor eggs, because we usually retrieve about 15 fresh donor eggs, 15 or 20 fresh donor eggs. And when we fertilize this amount of eggs, and we have a wider choice of embryos to transfer. And just to compare, when patient choose only 6 frozen eggs, of course, we will not have such a wide choice of embryos, and that's why the pregnancy rate can be lower. But if you will choose about 12 or 15 frozen donor eggs, the pregnancy rate will be, I think, the same, about 50%.
Excellent. Thank you so much for answering this question as well. And here's the next one. What incidents have NK cells on implementation?
For NK cells, it's a very hard question, because I think it's more for specialists in immunological field. Uh, right now, there are a lot of studies, evidences about role of NK cells in implantation failures, and some offers suggest some treatment options, but the sample sizes are very small, so we cannot give any suggestions for our patients. This is just experimental studies, so that's not for everyday clinical practice, I think.
Okay, excellent. Thank you once again for your question. Now, we do have quite a long question, okay, and then we also have a follow-up. So
Um,
we get to it right now.
I will read.
Yes, exactly. I'm age 45, have had 9 runs on egg IVF, about 14 embryo transfer, all fertility, only had implantation once 5 years ago, which ended in miscarriage. Due to my age, we now moved to donor egg own sperm. We got 6 very good quality embryos, which we froze. I've had 2 embryos transfers from this, one a blastocyst each time, but both failed. We have 4 good frozen embryos left. Should I get other tests first before trying again with next embryo? And just let me go to the follow-up straight away. In follow-up to my question, other tests before next transfer, I should have said I've had hysteroscopies, basic Chicago test, nothing showed up. Some people mentioned alpha testing. Is this something you would recommend?
Well, in such a huge story, um, if there is no any pathology, probably you can try to do PGT for these embryos and try once again if you will find euploid embryo, and maybe in such a story we can suggest using of surrogate mother. But as for other tests, I'm not sure that you need to do all these tests again. In our clinical practice, if you have checked hysteroscopy, laparoscopy, karyotyping, and so on, you can just follow the examination list and all the examinations which are mentioned in our guidelines. We have valid dates, so sometimes patients need to repeat some tests. But as for the whole story, I suppose PGTA and probably surrogacy.
Okay, thank you so much again for answering this question. As I mentioned, we have like 2 or 3, questions left. So this will be like a final call for your questions. So if you have any left, go ahead and type them in the chat section. And now let's go to the next question. How long does it take approximately to reach the right thickness when using estrogens?
Well, usually 2 weeks is enough, and usually we start estrogens at the beginning of the cycle, on the second or third day of the cycle, and by the day 12 or 14th of the cycle, endometrium thickness is enough, and we can prescribe progesterone.
Excellent. Thanks so much again for answering this question. And we have another one about egg donors. Can I choose my own egg donor if I want to use a family member? Is it possible?
Yes, you can choose your own egg donor, but if you are going to do the egg donation program here in Russia, this egg donor should be younger one, 35 years old. She should has a normal karyotype, and she should pass all the examinations mentioned in our guideline, and she should be at good somatic health. Yes, you can choose your own egg donor.
Okay. Thank you so much again. There's a follow-up question as well here. So I'm 44 with a very low age, 0.02. Do you think I can try via full?
In fact, at such a age, the chances that own eggs are very, very low, and I always prefer to say the truth to my patients. So the chances are very low, and I will recommend donor eggs. But if you have no contraindications for ovarian stimulation, and if you really has antral follicles, we can try to do the stimulation. But I think patients always have to know real chances and take them into consideration while making a decision.
And once again, thank you so much for answering this question. At this point, we do not have any more questions, but some
Oh, that's all?
yes. So I just want to give it a minute to make sure that we do not have any more questions, so we do not miss anything. But at least at this point, it looks like we do not. No, sorry. There
Oh,
it is.
one more question.
I missed it. Here it is. Follow-up question about use of estrogen. Is it also 2 weeks for someone, for example, already a year in menopause?
Well, for estrogen in menopause, if patient didn't take hormonal replacement treatment for menopause, 2 weeks will not be enough. In such cases, we need to evaluate the uterine condition, to measure the sizes of the uterus and decide how to prepare. So in menopause, if we are talking about menopause, especially post-menopause women, usually we prescribe hormonal replacement treatment for a few months. Mm, Actually, it's minimal duration. I think is about 4 or 6 months before the IVF, and only after that we can prescribe estrogens for endometrium preparation.
Perfect. Thank you again so much. And well, it looks like it was our last question, but I just don't want to jinx it. Okay, that's what I thought. Here's another one.
Yeah.
And looks like it will be our last one. Is it possible to test the sperm of my husband on the day of IVF?
Well, embryologists always test the sperm before the fertilization, but we suggest to examine husband's sperm before we start program, because we have to plan and everything, because sometimes we can find some abnormalities and we will need to check some additional tests. So it's better to check it before you come, and in fact you can check not only in our clinic, you can check everywhere, everywhere you like, and send the results, and we will decide about the appropriate program. And the embryologist, of course, will check the sperm at the day of fertilization.
And excellent. Thanks so much again for answering this question. And well, there is one more question that has just appeared here.
Yeah.
So let's go to it. Should I be on any hormones before starting IVF donor program?
Well, that depends on your own condition. So, for patients who have abnormalities in their ovaries function, usually use some hormones before starting IVF and even before starting donor program. Patients who have no any abnormalities in the ovaries function and choose donor program for another reasons, they cannot use hormonal treatment before. So it depends on each clinical case, and you are welcome to ask question and to send some kind of questionnaire, some kind of your history, and probably I can answer directly.
And thank you so much once again. We have one more question, very short
Yeah.
So do you have any color donors or?
Well, unfortunately, in Russia, it's very hard to find color donors, so we don't have black donors. If you want to find black ones.
Okay, understood. In the meantime, one more question showed up here. So do you do surrogacy programs as well?
Yes, surrogacy is legal in Russia, but it's performed under medical indications, not under the wish of patients, but under medical indications. We do surrogacy. It's legal. Yes.
Okay. Thank you so much again for confirming that. Well, at this point, it doesn't seem we have more questions, okay? But
Yeah.
also, just in the meantime, please let me remind you that if you have any questions that you would like to ask and be connected with the team, and of course, Dr. Valentina, you can use this link right here, and there will be your option to just click on ask your question, and it will be forwarded straight away to the team. Um, and in the meantime, we just received another question, okay? So if you don't mind, let me show you this one, okay?
Yeah.
So my
See.
uterus contract locked. Is that a sign of abnormalities?
Well, what do you mean when talking about uterus contract a lot? Usually, if we're talking about uterus examination, first of all, we can check ultrasound, and then we can check hysteroscopy, in some cases laparoscopy, and then decide if there are any abnormalities in your uterus and other organs of reproductive system. So the contract is not a pathology itself.
Okay, perfect. Thank you so much for clarifying this for us as well. And someone is typing, so I'm not sure if it's like a thank you. Yes, it is.
Hello,
Just
welcome.
just wanted to check it. Okay, so I believe we will finish for today. However, as I've mentioned, if you have any questions left, go ahead to this website that I have sent in the chat section, and you will be able to get in touch with the team and Dr. Valentina team as well, of course. Well, thank you so much, Dr. Valentina. It has been a pleasure to have you here, and thank you for joining our Stronger Together initiative. It has been a pleasure. You've been excellent with all the answers, very detailed ones. So thank you so much for that, and for your time. I know it's quite late in St. Petersburg right now. So thank you for staying with us. And well, I just want you to see that there are more thank yous, not only from
Oh, thank you. Welcome.
Yes, there are some more um, thank yous. So let me just have a look. Yes, more of those. Well, is there anything else you would like to add?
Well, I'd like to say thank you for thank you for the audience, and that was a great pleasure for me to speak to you, and I hope I answered your questions, and hope I can help somebody of you. We will keep in touch. You can ask all your questions. Probably somebody forget to ask something. So we are ready to cooperate, and you are welcome to St. Petersburg, to ICRM, and hope to see you.
Perfect. And I'm sorry, I apologize, but it seems
Oh,
there is one more question, actually.
great.
Can you handle it? One more. Just one more. So I have been taking vitamins for some time, 2 months. Can it backfire?
Well, usually we prescribe vitamins at least for 2 months before planning pregnancy. But if you have taken it for more than 1 year, you can have a break.
Okay, understood. and hope that helps you as well. Okay, thank you so much for again, thank you so much, Dr. Valentina. Thank you all for being with us as well, for your questions. I definitely know it helped you even if a bit. So thank you for joining us over and over again. I know some of you have been joining our events very, very frequently. So thank you for sticking up with us and for joining our initiative. And this is a pleasure to help you out as much as possible. And once again, let me remind you that you can find all the events on our website, myivfanswers.com. And this event, of course, will be available there as well shortly. You can also follow us on our YouTube channel or Facebook or Instagram, and you will be updated with all of our events, upcoming events. And of course, we will be back here tomorrow at 6 p.m. UK time and then at 8 p.m. UK time. So again, we will have another topics to handle, another top experts to meet. So remember, tomorrow we will have a doctor from Czech Republic and also from Spain. So many different topics to talk about, to discuss. So well, huge thank you for joining us, Dr. Valentina. Again, have a lovely
Welcome.
evening. Thank you so much for joining us, and well, stay safe. And of course,
Yeah, stay safe.
hopefully we will be able to do it again.
Thank you.
Thank you so much. Good night,
Thank
everyone. Bye.
Bye. Good night.